So I, Dr. Prachi Uttekar, Associate Professor and HOD in the Department of Pediatrics, would like to extend a warm welcome to everyone on behalf of Dr. G.D. Paul Foundation, YMT Homeopathic Medical College, on today's webinar on the topic Homeopathic Management of Pediatric Disorders. As we all know, homeopathy treatment depends on the person's detailed history, his nature, his behavior, as we believe in the concept of individualization. But when it comes to the children, it becomes difficult, as children can't answer like adults. And hence, the role of observation becomes very much important in this. Hence, we need to take special steps to ensure the best possible treatment for them. And to guide us regarding this proper management of children, today we have with us a multifaceted personality who has changed the perception of a common man towards homeopathy. He is a homeopathic pediatrician, Dr. Praveen Jain. Sir is the director of HomeoCare, a chain of a pediatric homeopathic clinic having 15 branches all over India, which has done a phenomenal work in the domain of a child development or a treatment. Inspired by his special interest in child psychiatry, he deals with the pediatric cases with much ease. Sir is a faculty of predictive homeopathy. He is a visiting faculty in Brazil, visiting lecturer to Via Homeopathica Israel. Sir has been a speaker to various seminars and workshops all over India. Sir has authorized various books. Few of them are Essentials of Pediatrics, Essence of Pediatric Materia Medica, and Encyclopedia of Mind, and many more. So without much delay, I would like to move ahead. But before starting the session, I just want to give few instructions to the listeners that please mute your audio, and if any doubt is there, if any query is there, there is a question answer session at the end, so you can put your question in the chat box and the answer will be given. So thank you so much all. So now I request sir to kindly begin with the session. Thank you.
Good morning all. Am I audible?
Yes, sir.
So very thanks to the YMT Homeopathic Medical College for inviting me to share my experience in pediatrics. I thank Dr. Page Madam, Dr. Bagal Sir, Dr. Prachi and Dr. Sonali for giving me this opportunity to share my experiences in pediatrics. So I hope this whole batch is are all the students who are doing pediatrics, or there are other students also, Dr. Prachi?
Yes, sir. So this will be for the PG students and as well as the final year and third year students and interns.
Okay, so this is a mixed crowd.
Yeah.
Right? So I will today, since this is my first lecture in YMT Homeopathic Medical College, today what I'll be doing is just a basic introduction and basics of how I approach pediatric cases, and then in future lectures I'll take you in more depth and details on to see various other illnesses and various difficult cases in pediatrics. So my topic for today will be on pediatrics. I'll share my screen. Able to see my screen?
Yes, sir.
So thanks to the YMT Medical College for giving me this opportunity. So what are the difficulties in pediatric practice? So the first difficulty is that the verbal history is missing. We have a child who is in front of us, an infant or a toddler, and he cannot express his symptoms. As we do a case taking in adults, where we start with the history, we ask them, what are your complaints? What are you suffering from? Here, the most important point is that the verbal history is missing. Second difficulty which I faced when I started my pediatric practice was there was no pediatric materia medica. We had many materia medicas, the Fatag, the Allen's Encyclopedia, but the pediatric materia medica or materia medica focusing only on children was missing. We had at our, during my college times, only we had was a small booklet of Borland pediatric materia medica, but no other materia medica was available. In pediatric practice, observation is very important. You have to observe the child and note down those observations, and you should understand what every gesture of a child means. And finally, the whole family is in panic. So this is a very important aspect of to be successful in pediatric, is that you have to convince the family that they are in right hands. If an adult is having fever, then nobody cares in the family. But if a child is having fever, then the whole family, the grandparents, the parents, the aunts, uncles, everybody is in panic and they want that the child should get relief immediately. So in practice, we have this difficulty where the whole family is in panic and they want to address the symptoms or they want the relief for the child immediately. They can't wait long. So these are the few basic difficulties which I had faced in when I started my pediatric practice. But as I went ahead and I started discovering in depth into the observation of children, I found that the pediatric practice is very easy. Why? Because the history is unmasked. There is no adulteration or compensation in the history. So I'll give you a few examples of my clinics during my whole lectures. Now, there was a child, and this child walked into my cabin, and he was behaving very rudely and arrogantly. And when he was looking at me, he shouted at me, and he said, "ये आपका कपड़ा कैसे पहना है आपने? ये गंदा कपड़ा है." So looking at my clothes, he was not happy and he observed something in my clothes and he immediately commented on my clothes. So what does this mean? That the child, when he walks into your clinic, he doesn't have any inhibitions. He will talk what he observes. So the history, whatever is given by the child and by your observation, is a pure history. There is no adulteration. An adult, if he is angry with you, but when he walks into your cabin, he will portray a very nice face. So he will always put up a facade in front of you when you are taking history for an adult. But when you talk of a child, there is no facade. And that is the biggest advantage of pediatric practice. Pediatric practice is WYSIWYJ, which means what you see is what you get. So what you see is exactly the pure innate nature and characteristic of the child. The emotions are not hidden. He will express his emotion. So if he is restless child, he will come around and walk around your clinic and he will touch everything. He will do whatever he wants. He will shout, he will get angry, he will throw toys. So whatever emotions are there, it is completely seen, or there is no masking or no facade in his expressions. And that makes your job very easy. So in adults, you have to probe and you have to find out what is behind the history which the patient is throwing in front of you. The patient might be saying that I am very calm and composed, an adult. But you have noticed that outside, when he was in the waiting room, he was fighting with the reception. So when you see an adult, there is always a masking and a facade in the history. Whereas the advantage of pediatric practice is there is no facade. Whatever is there is you see. And second thing, pediatric cases which I have seen that they are not much abused by drugs. So their sensitivity is very high. And so when you prescribe the right remedy, the results are good. So in pediatric cases, we get good results if the remedy is right, quick results. So these are also, so one side we talk of difficulties in pediatric practice, at opposite side also there are many advantages of pediatric practice, provided you understand what the child is doing. So if we can understand what the child is doing, and if you can manage or interpret or decode the expression of the child, the practice becomes very easy. So let us start with the case. I'll just narrate a small case in front of you. This was an infant of 4.5 month old, 5 month old. She came to me with complaint of BCG lymphadenitis. Now, what is BCG lymphadenitis? That it was because of the side effect of BCG vaccine. There was an enlargement. The lymph node in the axilla were enlarged, and it was suppurating. The pediatrician diagnosed this as BCG lymphadenitis. So now the challenge is that for us is that this is a 5 month old child. Now where to start the history? Any hints? Dr. Prachi, if somebody wants to ask any lecture, they can unmute themselves and then also ask during the lecture, because I would
Okay.
also like to have an interactive session where if you are stuck up at some point, you can ask me questions and I'll try to clarify there.
Okay, sir. Sure.
So any hint, how do you approach if you have a 5 month old child, how do you approach the case?
So students, you can unmute yourself and
Just
please answer.
when you want to ask question or you want to answer something, unmute and then mute yourself again so that the others are not disturbed.
Yes, yes.
So let us see the history first. So, difficult, it was in my initial days of practice, taking the history itself was very difficult. I was not knowing what to ask. This is my case of my initial days of my practice, and I am presenting it as it is. Of course, today my approach has improved a lot, but I will present the history as I saw the history at that stage. Okay, so then as we normally start, I started with the chief complaint. So this was a child came to us in June 2001 with the swelling in the armpit. So then we asked, as in pediatric cases, we asked the vaccination. So next step we asked was, what is the vaccination? What are the vaccinations which are given to him? So all the basic vaccinations were given. The BCG was given. The first triple was given. Hepatitis B was given. Second dose of hepatitis B was also given. So this was a vaccination history which we got from the patient. Then we asked about the birth history. कि इसका डिलीवरी कैसा था, ये इसका बर्थ कैसे था. So the birth weight was 3.25 kgs. This was a C-section because of the cord entangled around the neck. The child cried immediately after the birth. The child took breastfeeding properly. So this was we try to elicit and try to ask few questions about the details of the history. So these are the part of the history. So vaccination history, birth history, his nature, these are all the part of the whole pediatric case taking. Then we asked about the development history. The child was 5 months old. So we asked about his development. What are his milestones? The child has a social smile and he turns his head to the sound. So whenever any sound was there, he was turning his head around. The child turns side to side and lies on the stomach. The child lifts her head well, holds things in his hand and put things in the mouth, holds head, started taking top feed. So the milestones were all seems to be normal. The child was lifting his head, was turning around in the bed. We tried to understand the nature. We asked इसका क्या क्या करता है ये बच्चा. So when we are to ask the nature of the child, we ask कि ये आपने ये बच्चे में क्या क्या चीज observe किया है. So we asked the parent directly कि what have you observed. The parent says that the child does not like to lie down without anyone around. मतलब अकेले वो रह नहीं सकता है, उसको कोई ना कोई पास में चाहिए होता है. Someone has to be there. He wants people around, and he fond of some particular. So he was very attached to the grandfather, and जब भी grandfather साथ में होते, तो he was very happy. She was very happy. Sorry, this is a female child. The child likes red color. If finds anything in red color, she is attracted towards it. So this was the only history what we got. And then at that time, what we used to also do is we used to take mother's history also. This is the pediatrician's note. Diagnosis was BCG lymphadenitis. We asked about the physical generals. Thermally, the child was hot. And the thirst, she was thirstless child. Then we proceeded towards the mother's history during pregnancy. Now, this is very important. You know? At that time, we used to, so this is what the data was available. So very difficult to prescribe on that data. And so we wanted to understand the other some symptoms. So the next possible alternative with us was to take the mother's history during pregnancy. So we started asking what is the mother's history during pregnancy. The mother said that she had left-sided backache with swelling of the leg. She had to take rest during 7 months for 15 to 20 days to avoid premature delivery. She was advised bed rest. There was a lot of work pressures. She had to be present at the home and at the office. There was no leave granted to her during the pregnancy. So a lot of office work pressure was also there. At the same time, she had to do her household chores. So there was a lot of work pressure from the house and at the office also, both the places. She was tense about the pregnancy because this was the first pregnancy. And she was very sensitive. Anything that happened around her during the pregnancy had left a deep impression on her. That's what she said, that आसपास में कुछ भी होता था तो मैं उसके बारे में बहुत सोचती थी. She developed typhoid during the 7 month of pregnancy, and that was also she was advised bed rest. She had also developed few boils during 7 and 8 months of pregnancy, and she had taken antibiotics. Her father-in-law and mother-in-law were not keeping too well during the pregnancy. She was also tensed about them, as they should keep well and nothing should happen about to them. She was anxious about the health of the father-in-law and the mother-in-law. She married since 1.5 years, has good relationship with husband, prefers to be in a clean and nice surrounding. She wants cleanliness. She likes to keep everything arranged in the cupboard, does not like things kept improperly. But since she lives in joint family, everything can't happen according to her wish. So she was also okay, and she was adjusting to the in-laws. Some irritation and frustration was seen on the face sometimes when things were not kept properly, because she had a habit to keep everything at its own place. She was not a good decision maker. She has to consult somebody before taking any decisions. Especially, she used to consult husband to take any decisions. She can't mix easily with people. She can mix only with known people. Physical general of the mother. She likes sweets. She likes chips. Thirst is less, 3 to 4 glasses per day. She is constipated. perspiration is scanty, and thermally she is chilly. There was some allergy on the legs also. She had an application of betnovet and she was taking anti-allergic medicines during pregnancy. Diagnosis of the case was BCG lymphadenitis, and the child was prescribed by pediatrician syrup Ipcazid 1.5 ml and syrup Arsin 2.5 ml. This was a routine anti-tubercular medicines were started, but she was not feeling better, so they came to us. Yes, and this is the history which we have got. Tell me, any suggestion of the remedy? How should we approach the case and how do we solve this case? I would like to have a discussion. Anybody wanting to give opinion on a remedy or an approach or symptoms or repertorization? They can unmute themselves and answer. Yes?
Yes, students be volunteer and answer. Pediatric department,
The key to
students.
success is to participate. Those who participate will learn better other than those who don't participate and keep mum. So leave your inhibition and start answering. See, this is a case which you will now, after a few years, you will be starting your practice. MD doctors, you will start your practice in few years, 1 or 2 years. And the same case suppose comes to you, what will you do? So you can, there are two aspects I want feedback. Did I go wrong anywhere? Was the history sufficient? Was the history insufficient? Was my approach right? Was my approach wrong? Or do you have any suggestions to improve in the case taking? This is the data which we have. I hope you understand my question. Suppose this patient comes to you, what will you take? Or क्या चाहिए आपको data? Is the case taking complete or incomplete? Come on. Otherwise, I'll start asking one by one names. I'll take a name and then I'll ask answers from you. See, participation is very important. Otherwise, this is just, I will come here, I'll talk something, I'll go back. You will not know anything or that will not help you in your practice. So participation is very important. Tell me now, what do you feel?
Good morning, sir.
Yes, Shivani.
Sir, I have one question.
Yes.
We have taken baby as thirstless. Baby is breastfeeding. How can we take it as a thirstless patient?
Very good question. Shivani, in children or in infants, we take the amount of breastfeeding as synonym with thirst. Okay. So we ask the baby how many times the mother is feeding the baby and what is the type of feeding which the baby takes. So there are many rubrics for that. So the key or the idea is that take the amount of breastfeeding as a thirst, because baby is exclusively on breastfeed. So till 6 months of age, if the baby is taking more than 6 times feeding, then we take it as thirsty, and if it is less than 3, then we take it as thirstless. So the number of times the baby is breastfeeding is being taken as thirst or thirstless. So breastfeeding is synonym with thirst in the infant case taking. Second thing is also during the case taking of infant, you have to see how the baby is breastfeeding. So baby is breastfeeding fast, baby is breastfeeding slowly, baby empties both the breast, or she is contented with only latching on one breast. She is having any preference of left side or right side of the breast. what is the position which she is taking during breastfeeding. She wants to held upright or she is okay. During the breastfeeding, she is sucking very fast, or she falls asleep during breastfeeding, or she falls asleep after the breastfeeding. So these are the various points, Shivani, which we try to understand in the babies. So for infants, history of breastfeeding is very important, which I have also enumerated in my book, Essential of Pediatrics. So the approach of pediatric cases, I have outlined the whole case-taking approach in the book. So from that, we understood that the baby was thirstless. Got it, Shivani?
Yes, sir.
Okay. So what is the remedy, Shivani? Do you come to some conclusion or you want some more information?
Sir, more information.
Okay, so tell me now where I have gone wrong, what I should ask more. This was the baby in front of me.
Okay. Sir, even we have to give medicine for mother as well, because mother suffered a lot during her pregnancy. So that could have caused many mental symptoms reflecting in baby also.
So what is your inference?
Uh,
So you say that mother's history should be taken important?
yes, sir. Because mother's mental health ultimately had some impact on baby and baby's thinking process also. Hello.
Yes, yes, tell me, continue.
So that is my opinion, sir.
Very good. So that is why we took the whole mother's history.
Yes, sir.
Understood, Shivani?
Yes, sir. Yes, sir.
So that was, when I started my practice in 1994. Okay, this is a case in 2001. And what you see on the screen is it was exactly my situation when I was practicing. Kya lena hai? Because you have a baby, you have a infant in front of you and you don't know what to ask. So kya karenge? Take the mother's history. So we took the whole mother's history to prescribe for the child. Okay.
Yes. Yes, sir.
Any other suggestions?
And sir, baby's physical generals are even not we have taken into consideration.
Like what?
The thermals.
Thermal's baby is hot.
And the appetite also, because we are taking breastfeeding as a thirst. Then what about the appetite? As
We
you
don't take appetite in infant. We don't take appetite. We take directly as thirst only, because thirst is more important than appetite.
Okay, sir.
That we have taken. And Shivani, this is a 5-month-old child. Or kya appetite to kuch hota nahi. They don't.
Yeah, they just breastfeed.
This baby was started on top feed. Normally we see infants till 6 months of age. We don't advise them any top feed.
Okay. Yes.
So craving है मुझे तो कुछ मिलने वाला नहीं है.
Yes, sir.
So what is the mother's remedy? What should we see this? Understand this challenge. This is a case of not simple cold and cough, but this is a case of BCG lymphadenitis. So we have to be very sure of the remedy. Already the child is taking allopathic treatment, not better with anti-tubercular treatment.
Yes.
Any other suggestions? So what are the options we have? We take the mother's history, we prescribe the mother's remedy, or we prescribe the child's remedy. क्या करना चाहिए? Shivani?
Yes, sir.
Tell me now. Should we prescribe for the mother or should we prescribe for the child?
Sir, we'll have to prescribe both.
Both.
Yes, sir. For mother, because her mental status, and for child, and for that it should not affect her breastfeeding, and to baby, and for baby just to go through the acute phase.
So this is very good answer, you know. So I will, when the next time the parents come, I'll say कि बच्चे को दवाई चाहिए तो मदर को भी पैसा देना पड़ेगा, फादर को भी पैसा देना पड़ेगा, दोनों को हिस्ट्री देनी पड़ेगी. Why mother's remedy? Why not father's remedy? Why not take father's history during pregnancy? Do father have a role in the child development or no?
Father has a role in child development, obviously, but mother is breastfeeding right now. So whatever mother will think, it will affect her breastfeeding, and then it will affect her baby also. So important goes to mother on the more side.
So you mean to say that the infant is not an individual. So mother is an individual. We have to prescribe for the patient. So we should prescribe for the mother or prescribe for the child.
Sir,
So mother, suppose is the mother history remedy is A. So should we directly give A remedy to the child? And what if the child remedy is B?
For acute, we have to prescribe acute for
This is not
baby.
an acute case. Sorry, Shivan. This is not an acute case. This is a case of BCG lymphadenitis. Tuberculosis does not come under acute. This is not fever.
Yes, sir.
This is not acute. Chronic.
So now I am confused.
Exactly. You know, even I was confused. You know, confusion is there. From there only we find solutions. So during when I started my practice, that was a prevalent norm at that time, that take the mother's history and prescribe the mother's remedy to the child. And why this was prevalent? No, because it was difficult to find the child's remedy. So in this case, Shivani,
Yes, sir.
if I tell you that the child remedy is B and the mother's remedy is A, and both remedies are different, now would you give A or would you give B? You understand my question?
Yes, sir.
Child remedy, we have found out that it is B and mother's remedy is A. What will you do in this case? A or B?
Sir, don't know.
Sorry?
Sir, really don't know.
So why to give mother's remedy? If I know the child's remedy, I will give the child's remedy. I am not bothered about the mother's remedy. Understand the case, understand the scenario. Since in practical, it is very difficult to find the child's remedy, we have found out a solution to give mother's remedy. Sometimes it works, sometimes it doesn't work. Are you with me?
Yes, sir.
So when I started my practice, the prevalence to prescribe mother's remedy to the child was because I was not knowing what is the child's remedy. I was having difficulty in finding the child remedy. But if I tell you today that there is a method to find out the child's remedy, then would you give child's remedy or mother's remedy?
Child's remedy.
Yes. So problem उधर था शिवानी कि हमारे को पता नहीं था ना दवाई कैसे निकालने की बच्चों में 3 महीने का बच्चे में दवाई कैसे निकालने की पता ही नहीं था. So solution था हमने मदर का remedy. So I'll share you one more practical experience. I'll share you a lot of practical experiences, today.
Yes, sir.
So there was a child who was, hyperactive child था. That time I was not knowing anything about autism. So hyperactive child आया clinic में. And he was so mischievous and so hyperactive that he was touching everything and not allowing me to concentrate on the case. तो मैंने क्या बोला मदर को कि आप एक काम करो, आप अभी आज घर जाओ और कल सुबह आप अकेले आना, बच्चे को घर में रख के आना, आप आ जाना, मैं आपसे हिस्ट्री लेके फिर दवाई दे दूंगी. And the patient never turned up. This was a referred case to me. So then I inquired with the other patient who were referred. तो she commented कि अरे वो जब आई आपके पास ना, तो वो बोला कि ऐसे कैसे डॉक्टर है जिसको दवाई देने का उसको घर पे भेज दिया और मेरे से दवा हिस्ट्री ले रहे, मदर की हिस्ट्री ले रहे. And then I realized that this is not right. You know what I was doing. Are you with me?
Yes, sir.
Such examples in your practice make your eyes open. So I realized नहीं, I was doing wrong. अरे जो बच्चा मेरे सामने है, जो तोड़फोड़ कर रहा है, मस्ती कर रहा है, वो ही तो उसका symptom है. I should prescribe on that symptom rather than sending the child home. And that was the reason when I after a few years, when I renovated my clinic, then now in every clinic we have a child observation room. So the first slide which you saw, that the play area was there, which we call as a child observation room. So it is a specialized room where we let the child do whatever he wants to do. There are a lot of toys, books kept in that room. So this allows us, for me, to understand the child in its natural state, or that has helped us to understand remedies of children of all age group. So the problem here in this case, coming back to the case, is that mother's remedy. See, mother was a chilly and the child isn't hot. If you see the thermals, how can I prescribe mother's remedy to the child? I have to find out the child's remedy. One more very good example which I'll share with you is that it was about my child, my own child. When she was born in 2009, sorry, 1999. So the first question which came was about the vaccination. As you know, we homeopaths, we don't want to vaccinate our children, and we advise our patients also. So my wife asked me this question, that what about vaccination? I said, no, we will not give vaccination. Then she was worried and she asked me next question. तो फिर आप अपना कुछ होम्योपैथिक दवाई दे दो उसको, ताकि उसका इम्यूनिटी बूस्टर रहे, and then we don't require vaccination. Do you face such question in your practice about vaccinations?
Yes, sir.
Yes. So now this is my own question, my own family, my daughter. अभी उसको वैक्सीनेशन देना कि नहीं देना? So I said नहीं, अगर उसका इम्यूनिटी बिल्टअप रहेगा तो उसको कोई वैक्सीनेशन की जरूरत नहीं है. नो पोलियो, नो बीसीजी, नो डीपीटी, नथिंग. So my wife said that, okay, build up the immunity. I said, yes, if you give her constitutional medicine, her immunity will build up. And then she said, okay, keep the constitutional remedy. Then I asked her, tell me the nature of the child. She said, it is your child also. You find out the nature. That was the key point in my practice. Then I realized, okay, so what is the nature of my child? You know, the problem, the solution comes when you face those problems. Sitting across the table was very easy for me to ask my patients, बच्चे का स्वभाव बताओ. अगर आप स्वभाव नहीं बताओगे तो हमारे को राइट रेमेडी नहीं मिलेगी, तो हम आपके बच्चे को ठीक नहीं कर सकते. In what about when it comes to your own child? So from there I started, reading more clinical psychology books, and then I started understanding the child. Are you with me?
Yes, sir.
To find out the nature of my child, I started reading clinical psychology books, and then I realized that you can find out the constitution or the nature or the characteristic symptom of every child. So from that day onward, I stopped prescribing the mother's remedy to the child's remedy. Got it?
Yes,
So
sir.
let us now see further. So how do you solve this case? So let us see the child first. Okay, so I'll share the video of the child. Now, this is the video of the child after few months of treatment, because initially I have not taken the video, but still you can see the innate characteristic of the child. Let us see the video of the child and then see whether we can come to the remedy or not. Okay. And can you hear and see the video? Dr. Prachi, can you see the video and the audio also?
So it has stopped actually.
It stopped, but it was
Yes,
visible, na?
it is visible.
Okay, so I'll start the video again. Okay.
Yes.
See, this is the child, the small infant in the pink t-shirt is the child. Okay, observe the child. Hello. What we do is, when we see a child, we try to communicate with the child by saying hi, hello, That is the way we greet the child. And when we see the response of the child, we see the child how, if it is a toddler, we see the child how he walks into the clinic. Then we examine the child and see how does the child reacts to examination. And then finally we see how the child settles down. So observe this child and then we will discuss on the prescription. Okay. Yes, tell me the observation. Anybody? Shall I play the clip again? See, observation is very important in pediatric. That's what the crux. When Dr. Prachi introduced about this pediatric lecture, she said that observation is the key to pediatric practice. Okay. So you have to, either you can type, somebody who wants to not talk on the mic and type. So yes, Dr. Geeta says that carried desire to be. Very good observation. Carried desire to be. Any other observations? You can type in the chat box also.
So clinging.
Clinging, yes, good. Clinging. So carried desire to be, clinging. Very good observation. Anything else? So to make things easier and to make things percolate in your mind, I'll restart the video. Okay, see the video again and we'll discuss again. Hello. Okay. So carried desire to be and clinging. Dr. Geeta, why do you say carried desire to be? If you can type or if you can unmute yourself and talk. Or somebody said clinging. Why clinging? Again, a note of caution that what we are trying to do is we are trying to directly jump to rubrics. Carried desire to be, because we know there is a rubric called as carried desire to be. We'll take that. We are talking of carried desire to be. Somebody said clinging. We know there is a rubric called clinging. So better point will be to explain what was happening. Don't jump into rubrics. Rubrics will come later. First, let us explain or let us describe what you saw on the video. Yes, can somebody participate? Anyone want to participate?
So when you approach the child got frightened and held the grandmother tightly. So fear.
Shweta, very good. So when I approach the child, can you be more descriptive? How did I approach the child?
Examine the child.
Yes. What did I touch?
Steto.
Yes, very good. Good observation, Shweta. Very good. So see, Dr. Sarita says fear of doctor. Yes. So this is the observation. We'll not talk of rubrics first. What we'll talk is that Dr. Shweta says that when I touch the stethoscope, see, this is a follow-up video. So understand, when I touch the stethoscope, she got feared. Then she turned around and got hold of the grandmother's pallu or sari, and the grandmother stood up. Okay, we'll see the video further. See this observation, and now we are seeing the same video in slow motion. See, observe again. See the way she turned around, cling on to the grandmother's pallu, Okay, and now the grandmother is standing up because I asked her to come near me for examination. So what do we hear now? The child is crying and her siblings are laughing. Okay, the child is crying. Okay, we'll see this again. See the light. Same child some other day. Okay, let us see the reaction now. Hello. Hi. Hello. Yes, now we have seen the child also. So we have the history, we have mother's history, and now the child also in front of us. Is it easy for us to prescribe now? Any suggestions now? So what we observed was this child was, so whenever you see a child, you first say, try to greet the child, say hi, see how he responds. Examine the child, say, see how she responds to examination. You say hi, see how she responds. So this observation is very important. We can prescribe for the child only on this small clip. I have seen many senior homeopaths prescribing on a small clip, and I was initially, as a student, I was surprised. And I said, how can somebody prescribe by just seeing a clip of a child? Then I realized that their observation was so strong that anybody can prescribe on this small clip also, provided you know how to do it. Come on, suggestions. Either if you feel shy of talking, then you can type in the chat box, but participate.
All students, please participate.
Dr. Geeta, Dr. Sarita. See, if you don't participate, you will not understand how the approach. It is very easy, but you have to understand the approach. Dr. Sarita says stramonium. Yes, why? Dr. Purti also says stramonium. Shall we prescribe stramonium? Okay, so let us go further. Let us see what to prescribe for this child. Describing is very easy, but if we try to understand the basics and we are grounded, if we think that we know everything, then it will not prescribe. So collate all bits and pieces of a jigsaw puzzle and form a image. So for me, I will just share my approach to pediatric practice. For me, pediatric practice, the whole materia medica can be divided into two. And I describe this as an approaching or a withdrawing group of remedies. Which means that when I approach a child and I see how the child reacts, if I approach the child and a child is taking that approach positively, I call this as an approaching child. But if the child takes that approach negatively and doesn't want me to approach and withdraws from me, I take that as a withdrawing child. Is this clear? This is the basic. You have to all say yes, then only I move forward. Otherwise, we'll just stick over here. This is the basics of pediatric practice. You have to agree to this. Tell me whether you understood. When I approach a child, I go to a child, and if I see the child as reacting positively, I take that as an approaching child. If the child reacts negatively, I take that as a withdrawing child. Child withdraws. Is this right? Is this okay? Now tell me whether this child was an approaching child or a withdrawing child. Come on.
Withdrawing.
Good, withdrawing. Why? Because the child was not happy with my approach. Okay. If you can understand this basic today, half of your pediatric practice become easy. Because with this just simple one observation, you approach the child and see whether the child is an approaching or withdrawing. You can divide the whole materia medica into two groups. Okay. So as I told you, pediatric practice is very easy. It is fun to observe the child and prescribe for the child. Pediatric practice has got observations. Then you interpret those observations and then direct question to confirm your observation. So when I saw this child, my observation was this child was a withdrawing child. The child was not happy to have me near him, was not ready for examination. So that was my observation. I interpreted this as a withdrawing child. And then now I'll ask few questions to confirm my observation. But what to observe? So what you have to observe, there are few facets of the whole pediatric practice that you need to observe. I'll guide you what to observe, how to interpret, and how to ask, how to confirm your interpretations. As I told you, it's fun to observe the child and prescribe for the child. If you understand it, then it becomes very easy for you to prescribe. So the whole pediatric approach can be divided into these basic three components. First is we see the interaction with the physician. When we see how did the child interact with the doctor, from that we find out the axis, which is called as the sociability, activity, destructibility axis. I try to find out whether the child is an approaching child or withdrawing child. Then we see the behavior in the clinic, how the child behaves in the clinic. This is more so for toddlers and preschooling and schooling child. That gives us the innate characteristic of the child. And then finally, we confirm the remedy by seeing the reaction to the stimulus. What we do is we try to stimulate the child. So here we try to examine the child and see how the child reacts. So based on that stimulus, we confirm our remedy. So these are the basic three components or three key areas of your observation. Observation, how the child interact with the physician, how the child behaves in the clinic, and how the child reacts to a stimulus. So let us try to understand this interaction of the child and the physician. So when we see the child, we try to find out whether the child is an approaching child or withdrawing child, that we call as the sociability, trying to find out the sociability of the child. So when we see a withdrawing child, we can divide the whole materia medica into two parts, the approaching and the withdrawing child. So we have snakes. All the snakes are approaching. We have spiders, we have bees. Snakes means lachesis, elaps, crotalus. Spiders means tarantula, mygale, Arania hexabola. Bees means apis. These are all approaching remedies. Sulfur, phosphorus, tuberculinum, lycopodium, veratrum. These are all group of approaching remedies. Okay. And if you see a child who is withdrawing, we have pulsatillas, we have chamomillas, we have most of the salts like the natrums, the kalis, the ignatia, the staphysaga, lycopodium. These are all withdrawing remedies. There are few remedies like lycopodium can be both approaching and withdrawing at different stages. Easy? So when I see this child, when I see a child, I see whether the child is an approaching child or a withdrawing child. If I see an approaching child, I have to think of these remedies. Then I stimulate the child. I see the reaction of the child. Based on that reaction, I can find out whether it is a snake or a spider or a bee or a sulfur, phosphorus, tubular. Or if I see a withdrawing child, whether it is pulsatilla, chamomilla, natrums, kalis, ignatia, staph, lycos. These are few examples. There are many more remedies. So let us understand what I mean by approaching child. An approaching child is an extroverted child or an uninhibited child. Means there is no inhibition when he is in the clinic. He can talk to me, he can approach to me nicely. So how do we see in infants and toddlers? The infants and toddlers, they like to play with new toys. They are curious to explore it. When you give a toy, they like to take it and try to explore it. They will give smile to new faces. They will go with new people. They allow you to examine. They greet when they come in the clinic or leave the clinic. And how do we see a withdrawing child or a withdrawing infant and a withdrawing toddler? They are slower to warm up to a change. They will avoid eye contact to new faces. They will not mix with other child. They will not allow you to examine. They will not greet you when you come in the clinic or leave the clinic. So these are the characteristics of an approaching child, and these are the characteristics of a withdrawing child. So the first point what we see is whether the child is an approaching child or a withdrawing child. Okay. This is the flow chart for children's. This has helped us in our practice. We see whether the child is an approaching child or withdrawing child. If it is a child, a withdrawing child, we see whether it is hyperactive or a hypoactive. If it is hyperactive, we see whether it is a destructive or a non-destructive child. Then we have a group of remedies for all the groups. Okay, so this is the flow chart, a very simple flow chart for pediatrics. I will share this flow chart with Dr. Prachi, and she will share this chart with you all on your WhatsApp group. So now let us find out the remedy for this child. So what is the sociability of this child? You can type in the chat box. What is the sociability? Child is approaching or withdrawing. We also already talked that the child is withdrawing. What is the reaction of the child? What is the thermals of the child? What is the thirst of the child? So sociability, reaction, thermals, and thirst. The child was a withdrawing child. Okay. Reaction. What was the reaction of the child? Can anybody tell me reaction of the child? Thermal, the child was hot. The child was thirstless. So only 1 point remaining now to find out the reaction of the child. What was the reaction of the child? Hiding, yes. Dr. Sarita says hiding, yes. Anybody else? What is the reaction? How did the child react? Crying, very good. Hiding, crying, anything else? So once you try to understand the reaction of the child and you try to add that into your withdrawing group, you find there are shades of remedies. So if you understand the reaction and you add to that your repatriation child, you can see the full gamut or the remedy will come out very nicely. Before we go that, because we are not clear what was the reaction, I will try to show you one more clip. Let us see this child now. I'll share one more video with you. Are you able to see the video and hear the audio also? I paused.
Yes, sir.
Okay, right. So as we did with the previous child, now we'll see one more child and note down his observation. Note down this child. How does the child behave? Okay. Yes, what was the observation? Come on. I will play the clip again for your convenience. Yes. Dr. Meghna says doesn't want to be touched, right? Good. What else do you observe? Wants to go out of the room. Wants to go out, exploring things, wants to go out. He was not wanting to go out, but there was a basin at the end of the room. So he wanted to play with the water. Playful. Okay. Dr. Alicia says playful. Okay. Shouting. Yes, Dr. Sarita, shouting. Shouting means what? What was he shouting at?
So when you were trying to examine, so the child was reacting by shouting
Shouting on whom?
on the doctor.
Very good. Good. So I will play the clip again. See these small clips, even for these are all small 10-15 seconds clip, but this is very important. If you can grasp these clips, your practice will become very easy. I'll play the clip again. See the child as a whole now. The child wants to go to the basin. Child is looking at me. I'm examining the child. Child is not ready to get examined, resisting the examination. Not allowing at all to be examined. The child is shouting back at me, hey! See the child is now in slow motion when I am trying to examine the child.
पानी में खेलेगा अरे मुंह बनाना काम बोलिए Okay. Ay, Papa, Robin, sí, Papa. Yo. También el cumpleaños. Anda, po. तो उसका डैडी के पास भी इतना नहीं जाता है
I asked कि ये नए लोगों के पास जाता नहीं है क्या? If you see the previous clip, previous PowerPoint slide, I said that what are the points for seeing whether the child is an approaching child or withdrawing child. I said वो दूसरे के पास जाता नहीं क्या? The mother says कि ये अपने पापा के पास भी नहीं जाता है. The child is not even ready to go to his father. नया कोई आएगा तो जाता है क्या किसी के पास?
नहीं जाता है मेरा भाई भी आता है नहीं जाता है
मेरे भाई के पास भी नहीं जाता है
तब्बू का डैडी के पास थोड़ा जाता है
ये चाइल्ड किसी के पास जाता ही नहीं है. ओके
ऐसे ऐसा करता है ना ऐसे करेगा
So we saw one more child. Now what is the what was now we'll try to again sum up the whole thing. What is the sociability of this second child? Let us talk of the second child. What is the sociability? Approaching or withdrawing?
Withdrawing.
Very good. So this is the first point. Don't skip these steps. If you skip this step, you will go wrong somewhere. Follow these steps properly. First thing what you have to observe is that observe whether the child is an approaching child or a withdrawing child. Okay, so we saw two children today. Both are withdrawing children. Okay, then we now try to see the reaction of the child. How does the child react? So both were withdrawing. Can somebody point out the difference between the first child and the second child? Yes. Is the remedy of the first child and second child same or is it different? Dr. Sarita says that the first child was frightful and anxious. Yes. And what about the second child, Sarita? The second child is a stubborn child. Very good. Good observation. Snappish. Very good. Stubborn, snappish. Geeta said the second child was bit hyper. Very good. Sujala says the second child was more irritable. Very good. Now I will tell you something more. There are only 4 basic reactions of an individual or of anybody. The reactions are anger, fear, grief, and jealousy. Okay. Note down this. Basic reaction of a child or for that matter any individual to a situation is anger, fear, grief, and jealousy. Okay. Anger, fear, grief, and jealousy. So we have this first child. See this first child, when I try to examine, the child does not allow me to examine. See this second child. What is the difference between both the child? Now, if I tell you that there are only 4 basic reactions. First one is fearful. First child fear, second child angry. First child is having fear. Second child is having angry. Do we all agree to this? Very good. So now everybody has become a pediatrician. This is what my whole lecture was about. Believe me, if you have understood this thing, your pediatric practice has become easy. The first child was fear, the second child was angry. Understand? Both are withdrawing child. Okay, we are talking of infants who cannot talk, they can only express themselves. Both are infant, they are not able to talk. But when I examine him, I see the reaction. So now I add, so both are withdrawing child. I first see whether the child is an approaching or withdrawing. I come to group of withdrawing child. Then I see the reaction. What is the reaction? I see whether the child is angry or fear. So the first child which had complained of BCG lymphadenitis, this child was the reaction was fear. Okay. So we see a child who is a withdrawing child. The child is a touch to me not child. Okay. So what basic reaction we have? We have fear and anxiety, or the child is an anger and irritable child, or the child is shrieking. So there are basically two reactions. If whether the second child was angry, the first child was fear. And when you have fear and anxiety, you will usually you can have the reaction as weeping also and shrieking also. Reaction is shrieking also and weeping also. Okay. So let us, if I tell you the remedies, so the child who is angry and irritable, we have antimony, chamomilla, senna, sanicula, bryonia, china, nux vomica. If the reaction is fear and anxiety, we have Lyco, arnica, kali, ruta, jalsemum, lachesis. If the child is weeping, we have antimony, silesia, pulsatilla, ignatia, tarantula, thuja. And we have, if the child is shrieking, we have antimony, kali, mercury, aconite, cuprum, belladonna. So now if I give you this chart, can we find out the remedy of the first child also and the second child also? What is the remedy now of the first child? Bolo. So we have withdrawing, we have reaction, which is first child was fear. Good. So we have gelsemium, we have pulsatilla. Very good. Good. Pulsatilla first child. If second child chamomilla. Dr. Swapnali says pulsatilla first child, second child chamomilla. Good. Now you answer this question. Should we prescribe for the mother's history? Should we prescribe on the mother's history or should we prescribe for the child?
Child.
Very good. Child. So let us see now what we see for this child. We saw this. So we have to prescribe from Lyco, arnica, kali, ruta, gelsemium, lachesis, gelsemium, pulsatilla. So now fear and anxiety, we have choices between pulsatilla for the first child, chamomilla for the second child. So I repertorize this case. This was my old repertorization. Today we repertorize in a little different way. But the child was withdrawing, hyperactive, hot, thirstless, aversion being approached, fear of being approached. Lyco. So the first child was prescribed Lyco, the second child was right, chamomilla. So we prescribe lycopodium for this child. Okay. I will tell you the difference between pulsatilla and lycopodium at the end of my lecture. So this is a case of BCG lymphadenitis which came to us not improving with allopathic medicines. Then we started this case with lycopodium 200 single dose. Now after we, Dr. Joan says gelsemium. Yes, I will differentiate between gelsemium, pulsatilla, chamomilla at the end of the lecture. First we'll see some more reactions of the remedy. So the remedy prescribed was lycopodium 200 single dose. Now, after the remedy is prescribed, what do you want to observe? Follow-up. What will be your follow-up criteria? What should we expect after the remedy? Okay, Yogesh, yeah, just mute. Right, good, okay. So aphorism 1 says that physician high and only mission is to restore the sick to the health. It is not just removal of the disease. We are not trying to cure your BCG lymphadenitis. That is okay, that we will do. But what is our aim is to restoration of sick to the health, which means When we prescribe, we have to see the changes at the level of disease. That means the disease should disappear, change at the level of mind, and Hering's law has to be observed. So it is not just that your job is over when you prescribe, when you give a remedy, but you have to see restoration of health has to be there, which is possible when you see the disease going, the BCG lymphadenopathy is getting better, the mind getting better, and also you have to see Hering's law of observation. So in the follow-up, we saw the swelling disappeared. These anti-tubercular medicines were stopped after 15 days of starting the treatment. I'll show you a follow-up video. Let us see whether there was any change at the level of mind. This was almost after, I think, after 8 to 9 months of treatment.
Hello. Good evening.
How are you?
Fine, children.
Design.
Thank you, children. Fine, thank you, children. Good evening.
The child previously was not ready to be examined, is now started opening up.
Good evening, children.
When the grandmother says, say namaste, the child is now greeting us.
Good evening, children. Hi, God. आज सुबह से सोते सोते बैठे
स्केलिंग ना अभी रात को नहीं सोएगा
नहीं सोएगा रात को अभी दिवस पूरा सो गया
give a smile
not all of us left hand put it. Hello.
Is this okay? The child, we saw improvement at level of the disease, that she was better with tuberculosis. Improvement at the level of mind. But no, this is not okay. Nothing in the world can disappear. So we follow this Hering's law of cure. We follow this chart of suppression by Dr. Vijayakar, who has guided us how we have to see the improvement of every disease. So when you treat a deep tuberculosis, you should not rest till you see disease coming down to the level of skin. Okay, so exterioration has to happen, and you cannot say the case is complete or the cure is complete till you see the exterioration of the case. We have followed this child. The child was followed after 3 years. The child developed blisters on the mouth. She developed aphthous ulcer. She also developed few boils. Okay, I will show you one more follow-up. See, the follow-up has to be a long-term follow-up, and we have to follow up this child. This is very important now. Prescribing is very easy, but you have to see that Hering's law of cure is being followed. So the follow-up has to be, whenever we present a case, the case has to have a long-term follow-up of few years. Only showing a case and the case is better is not important. Follow up the case for few years, and then you can claim that you have cured the disease. So I'll show you one more follow-up now. these follows are very short follows, but still worth noting down. This child actually used to stay next door. She was our neighbor. So most of the time she used to just walk into the clinic like that only. So most of the time you can see this child not wearing clothes, you know.
स्किन के इन्फेक्शन कैसे आ रही है?
इनमें पार्सल जैसा लगता है।
Now there are miliary rash on the body.
पापा काटे तो नहीं काटे मुझे काटे। वो इतना फोकस मैं दूंगी।
The child now allows to examine.
Your sensation?
विशेषण ऐसा हुआ ऐसा yes no चलो yes
Second girl? How are you?
ini चलो fine thank you चलो बढ़िया
Say ah.
चलो
Good. Ah.
So complete extravasation of skin was there. Let us now understand what is lycopodium. I will just share a few brief mathematics about lycopodium, and then we'll differentiate with other remedies also. So basically lycopodium, the axis is that lycopodium can be both approaching and withdrawing, hyperactive, non-aggressive or non-destructive. That is the basic axis for lycopodium. One of the most important point for lycopodium is that they want company. Okay, but what kind of company is very important. Lycopodium always wants company of people on whom he can dominate. This is very important. So they will want company of parents or friends on whom they can dominate. The important symptom for lycopodium is hard for inferior and soft for superior. So if a lycopodium child is there and situation where the child can dominate, he will dominate. So who are the most easiest individuals on whom lycopodium can dominate? They are the parents. So lycopodium will behave differently at different places. So in the clinic or outside the house, lycopodium is completely different. Whereas inside the house, lycopodium is completely different. Inside there are people on whom he can dominate. So there the child will be abusive, the child will be talking harshly with the parents. Whereas outside or in the school, the child will be very mild, very obedient, will never talk rudely, will always be appearing timid, will not talk much in front of stranger. But inside the house, the child will always be more talkative, dominating, censorious, contemptuous to father, striking the father, striking the parents. So we have this very key symptom of lycopodium, which you should remember, that is hard on inferior and soft on superior. To understand lycopodium, understand this symptom: hard or inferior, soft or superior. Inferior means जिसको हम दादागिरी कर सकते हैं. The lycopodium will behave completely different with those people. And whenever he see any superior or somebody in authority, there the lycopodium will be completely different. So you'll many times observe two images of lycopodium inside the house or in the office, where he can dominate a different picture. Outside, where his domination is not there, there a different picture. So lycopodium children have got these two images, inside the house, outside the house, as completely different. Outside they will appear as timid, mild, obedient, and in the place of authority, and inside the house they will appear as dominating, abusive, censorious, talking rudely to parents. Now lycopodium also wants company, but on the people on whom they can dominate. So they will always be surrounded by people on whom they can dominate. So typical, when you see a politician who is surrounded by his chamchas, that is a strong lycopodium. They'll always want to be people with on whom they can dominate, or people who can praise them. If they see some obstacle, some authority, they will like to avoid the situation. Now, if you see this child, if you go back to the history and remember the history, this child was having fear of being alone. See, we could not understand that symptom when we took the history initially. The child was having fear of being alone, and he wanted some company always of the, and more so of the grandfather, because the grandfather was very loving. So the important point for lycopodium again is that they want the company, they like the company on whom they can dominate. Lycopodium children are very diligent. They will always be good at study. They will be a good boy. They will be obedient, and they will always complete their homework. So there will be always a good remark for a lycopodium child in the school. But when you talk to the parent say that in the house he is very notorious and very angry and very dominating. But in the school he is always good boy image. He will complete his work. He will do his homework. So lycopodiums are very diligent children. Soric lycopodium is withdrawing because they have got anticipation. They have got fear and apprehension. They have got fear of strangers. So a soric lycopodium will be withdrawing. They have lack of confidence. Now, when we talk of miasm, we also see remedies in different miasm. That means we see each remedy as a trimiasmatic remedy. We see soric image as a different image. How does a psychotic lycopodium behave, and how does a syphilitic lycopodium behave? So soric lycopodium, we see that they have got a lot of fear and apprehension. They have lack of confidence. They have presence of strangers aggravation. Whereas when we talk of a psychotic lycopodium, inside they are very coward, but to hide their weakness, to hide their cowardness, they will appear as dictatorial, dominating. They are hard with inferiors and soft with superiors. Critical and fault finding at home, contradiction intolerant of. Now let us understand how does a lycopodium react if ridiculed. Suppose there is a stage program and all the kids are performing, and now we'll see how each remedy, and suppose the shows goes flop and the child falls down, how this child will react. So if this is a lycopodium, the child will say that अरे मेरे को तो dance अच्छा आता था. There is a performance on the stage and the child falls down and all people are laughing. The lycopodium child will say मेरे को तो dance अच्छा आता था, बट ये स्टेज अनइवन था, इसके लिए मैं गिर गया. They will always bluff and they will put the blame on others. They will say that I was good, I was performing nicely, but the stage was uneven and that is why I fell down. They're always concerned about their status, so we'll say big stories. Now the same reaction we'll see when, if ridiculed, how does a natural you react? So if this is a stage program and the child falls down, and if this is a natural mute child, they will feel very bad, they will feel hurt, and they will say, oh, because of me, my whole program got spoiled, my class did not get the first rank, and I am not worthy to lead. So natural will always criticize himself and feel that they are at the fault. And how does a pulsatilla react? Pulsatilla will immediately start weeping. They will start weeping because they want sympathy and consolation. So the reaction of pulsatilla will be weeping. They fear that they will lose the sympathy and love of everybody, of the class, of the parent, and though they will start weeping. They will start weeping so loudly that everybody will come to them and say, अरे रे कोई बात नहीं है, गिर जाते हैं, ऐसा तो होता है लाइफ में. Don't worry, don't cry so much. So this is a basic, as somebody said about the remedy pulsatilla, this is a basic difference between lycopodium and pulsatilla. In pulsatilla, they want sympathy, so they will cry very loudly, and in lycopodium, they will bluff or they will show off. They will not show their inner weaknesses. Pulsatilla is withdrawn but will express complaint to gain sympathy, will not come close, but from mother's lap will tell all the complaints vividly because they want treatment, they want attention, and then or else they will start weeping loudly. Dr. Prachi, can we continue for 15-20 minutes more, or shall we take a question answer session? It's already 1:41.
Yeah, sir. Yes, you can continue. Please for 10 minutes more. Yeah.
Okay, so we'll take for another 10-15 minutes more.
Yes.
Any questions or doubt till this stage? So you can ask me. Okay, so what to do in acutes? The same child came to us one day at 7 p.m. having fever. Now let us see the same child who was cured of BCG lymphadenitis coming one day in the evening at 7 p.m. with fever. Let us see the video of this child. The child came to the clinic at 7 p.m. complaining of high-grade fever. This was a child. The child came and sat, and then I took out the camera and started recording her acute episode. Observe the child and see and guide me how to go about in acutes.
अभी बात करते करते सो गई पूछो क्या हुआ उसको क्या हुआ
डॉक्टर चली क्या हुआ चलो मुझे तो चलो चलो तब इधर बंदा
नहीं अभी इसको मुझे सोई के लिए
मैं इधर दूंगी ना पांच तो दूंगी मैं मुझे लिया तो दूंगी नहीं मुझे होता नहीं
हाँ
मुझे होता नहीं नॉट कीपिंग वेल ऐसा
घर में क्या कर रही थी वो बात कर रही थी
घर में बात कर रहे चलो 9 मिनट वॉचिंग
should lie down like this and watching things. बोलो क्या बात बहुत कर रही है?
नहीं, अभी इतना मैं इधर आके बटन she's talking too much हो गया, कंटिन्यूसली बात कर रही है।
क्या बात कर रही है?
Want to stick का ऐसा generally but too much talking ऐसा।
मतलब क्या?
मॉर्निंग अभी फ्रॉम 9 डाउन देयर ना।
Clear.
तो मेरी अपस्टेयर्स से मम्मी आई, तो उनके उसको उनके पास उठ के बैठ के बात कर रहे हैं कि मैं जाके आया, मैं इसको देखा उसको देखा करके सब बात कर रहे हैं।
This child came to me one day in the evening with fever. Yes, tell me now, what is your observation? The child is dull, drowsy, very good. And
पानी पिया उसने अभी घर में जाके?
नहीं, पानी नहीं पिया। She has not had anything after that food का लंच का कुछ भी नहीं खाया।
पानी भी नहीं पिया?
नहीं, अभी उसको दूध भी नहीं चाहिए बोलते।
लेकिन पंखा चाहिए?
हाँ, पंखा चाहिए, पंखा चाहिए।
नींद आता है बोलते? आ करो बेटा, आ करो। और ऊपर लेके आए।
नहीं ना।
okay, so how to now approach this child? We have know the child remedy is lycopodium. Now the child came to us in evening with fever. We see this child. Can we find out the totality and can we decide what to do? Suppose this child comes to you in your clinic, what to do? What should be your approach? Dr. Akash is right. Yes, activity, thirst, thermals. What is the activity of this child? This is what we follow with Dr. Vijayakar's chart on theory of acutes. The child is dull. The Sarita says find out ailment from. There was no any specific ailments from. First thing is what should be the approach? We know the constitutional remedy of the child as lycopodium. Dr. Sarika says support desire. Okay, good. Let us now. The remedy constitution is known as lycopodium. In acute, what should be your approach? That is question number 1. Should we give lycopodium or we should give an acute remedy? Second thing, if you want to give an acute remedy, what is the totality? So everybody is saying that the child is very dull, drowsy. Dr. Sarika says dullness during heat. Dr. Sarita says drowsiness in fever. Deepita says dull child. Dr. Juan says good remedy which follows well after lycopodium, covering dullness, thirst and thermals. Very good. Is the child dull or is the child active? Let us now first come to this point.
Want to stick ऐसा generally but too much.
The child is talking a lot generally. बात करें वो.
मतलब क्या?
मॉर्निंग अभी फ्रॉम 9 डाउन देयर ना।
क्लियर. हाँ.
तो मेरी अपस्टेयर्स से मम्मी आई, तो उनके पास उठ के बैठ के बात कर रही थी, मैं जाके आया, मैं इसको देखा उसको देखा करके सब बात कर रही थी।
Tell me, the child is dull or the child is active? Dull. Mother says that the child outside was very talkative, बात कर रही थी.
पानी पिया उसने अभी घर में आके?
नहीं, पानी नहीं पिया। She had not had anything after after the lunch का कुछ भी नहीं खाया।
पानी भी नहीं पिया?
नहीं, अभी उसका दूध भी नहीं चेंज होगा।
लेकिन पंखा चाहिए?
हाँ, पंखा चाहिए, पंखा।
नींद आ रहा है मुझे। आ करो बेटा, आ करो।
Shivani says faking dullness. When I say "आ करो," she
ऊपर लेके आए।
is the child dull or child active? Shivani says faking dullness. Nurina says child is active as she is giving responses to the physician. Good. So let us now understand the child is dull or active. So we should prescribe a dull remedy to the child or an active remedy to the child. So we have now got two groups. One group is saying dull, one group is saying active. Activity is reduced but not dull. Very good. Dr. Norain says activity is reduced but not dull. So come on, it is dull or active, dull or active.
लेकिन पंखा चाहिए?
हाँ, पंखा चाहिए, पंखा।
आ करो बेटा, आ करो। ऊपर लेके आए।
The child came to my clinic and she was at this stage. So I thought this is very peculiar. So I removed the camera out and I started recording. So there was also few more minutes that she was doing this. Geeta says in her previous state constitution she was active and now as compared to that seems dull. Yes.
अभी बात है।
Now tell me, the dull or active? She was sleeping on the mother's hand.
करते करते सो गई।
I asked you, बात करते करते सो गई? मदर बोले नहीं सोई नहीं है. And then she
पूछो क्या हुआ उसको? क्या हुआ?
डॉक्टर चलो चलो क्या हुआ चलो मुझे तो चलो चलो कफ इनोड ना
नहीं अभी इसको भी जो सोई के लिए
मैं
attention seeking, yes. Deepan Vita says attention seeking.
किधर घूमगी ना पंच घूमगी ना मुड़ी लिया तो घूमगी ना ले नहीं मुझे होता नहीं
हाँ
मुझे होता नहीं नॉट कीपिंग बैलेंस
So Dr. Vijayakar has taught us a very beautiful saying: eyes do not see what mind do not know. So we are not able to see because we don't know mind. If your mind does not know a particular thing, we are not able to see that. This is I took time extra 5 minutes from you people to show this clip because this is very important now. Eyes do not see what mind do not know. So we are just bifurcating between dullness and activeness. can we have a remedy which is dull and also active? And if we have such a remedy which is dull and also active, can we prescribe that remedy to this child? Are you with me? A group says dull, a group says active, but if I can have a remedy which is both dull and active, can that be the remedy of this child in acute phase? Yes or no?
Yes, sir.
Very good. So here what I was, the aim to show this clip was so important, because many times we don't see the totality. It is like the story of an elephant when people are blindfolded and everybody touches a particular part and then interprets it. So we see a part and then we jump to rubrics or remedies. But if we see the totality, then you'll never fail. So as in pediatric case, I was saying that see the totality, see whether the approaching withdrawing, see the reaction, thermal thrust, can get a remedy. Here also I wanted a remedy which was dull, which was sleeping, but when aroused, she is active. Get my point? I want a remedy which is sleeping, but when awakened is very active, and that was the remedy of this child. Anyone guess? Anyone guessing this remedy? Can anyone guess the remedy? ऐसा कोई रेमेडी है क्या जो सो रहा है बट ऑन अवेकेंड दे आर एक्टिव? Arnika, yes. No, not so dull. Arnika will be touched to me, not completely. Yes, Dr. Purti, right. This is opium. Okay. So opium, if you read Dr. Vijayakar's book on acute, he says very clearly. So that was a very important point. In under sleep overpowering, he writes 3 remedies, and he says after waking, what does the child do? So sleep overpowering, after waking, active, that is opium. So we prescribe this child opium. And I said you bring the child after some time. I prescribe, I said don't give anything, just after some time bring the child to me in 1 hour. Let us see the follow-up in 1 hour. This was the child after 1 hour.
अभी she had little water, but कुछ कॉफी या बोर्नविटा कुछ पिएगा, कुछ नहीं चाहिए होता है, कुछ भी नहीं चाहिए, भूख नहीं है, पसी क्या लिया?
She doesn't, after 1 hour when the mother said कि वो गई, बाद में मैं उसको बोला कुछ बोर्नविटा कुछ चाहिए, she said नहीं कुछ नहीं चाहिए मुझे.
क्या होता है श्वेता?
चल वहाँ तो चल पे डॉक्टर எடுக்கறாரு चल किधर दुखता है बोलो?
फीवर मेजर किया अभी?
नहीं फीवर जो विषम नहीं,
अभी ठंडा है बॉडी?
अभी थोड़ा ठंडा लग रहा है, मैं जब भी आया और उसमें डिफरेंस है, इनका परीक्षा जल्दी चल रहे हैं अंकल.
फीवर अभी भी है उसको, मेजर नहीं किया, बट स्टिल थोड़ा सा वार्म है. When I saw this child, I said that I saw something. So what to observe when you in the follow-up, immediately after few hours or few minutes after when you prescribe the right remedy? Do you observe any change in her?
किधर दुखता है बोलो?
फीवर मेजर किया अभी?
नहीं फीवर जो विषम नहीं,
अभी ठंडा है बॉडी?
अभी थोड़ा ठंडा लग रहा है, मैं जब भी आया और उसमें डिफरेंस है, इनका परीक्षा जल्दी चल रहे हैं अंकल. इनका कण्ण में ये नहीं चल डॉक्टर चलो इधर किधर दुखता है बोलो? इधर 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 किधर दुखता है?
क्या है तुमने अभी? पानी पिया और क्या कुछ खाया नहीं? बिस्किट नहीं खाया? क्यों नहीं खाया?
Observe the child.
शिल्पा को दिया, मदर को भी दिया, चाहिए बोला, नहीं चाहिए बोला, नहीं चाहिए.
शिल्पा को भी दिया, गौतम को भी दिया. और क्या होता है?
कुछ नहीं
என்ன இது வருது இல்லையா
இது
नहीं चल रहा ये वर्ड चल कफ होता है सर
कब होते हैं?
कब होता है?
हाँ,
अच्छा, ये मदर का है? हाँ, ये किसने लगाया?
ये मम्मी लगाया
मम्मी लगाया?
हाँ,
खाई के लिए?
मेरे को चाहिए
तुमको चाहिए? तुमने बोला मम्मी को?
हाँ,
क्या बोला?
चाहिए मम्मी 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 निकाल के मैं मम्मी को निकाल के दिया मम्मी मेरे को ये सब करके ये सब किया
आप कुत्ता है
डॉक्टर
टिकट डॉक्टर कुत्ता है
हम कौन
मैं
So I saw this child after 1 hour. I saw something in this child and I said, yes, my remedy is right. It is working. Even though the fever is not down, it will settle down. Did you observe something? How do you judge in initial few moments, few hours that your remedy is right? Because in acute also you have to act very fast. As I told you in the first part of my lecture, initial slide, that the family is always, in pediatric cases, the family is always very anxious. So they are very in the panic state. And you need to be very much clear in your observation that yes, my remedy is right and it is acting. Can anybody tell me? After the dose, what was the change which told me that I was very sure that my remedy is acting? Dr. Vijayakar has mentioned this very nicely in his book Theory of Acutes. What did you observe?
He was talkative after the dose.
Yes, good. She was, but she was also talkative previously also little. But of course, that right, she was more talkative. And anything else? That is right. She was talkative and she was better. Then comparatively in 1 hour, she was much better. She was talkative. Anything you noted in our physicals? Can you tell me something? Activity increased, no more drowsy. Very good. Yes. Weakness generals improved. Yes. She was talkative, alert. Yes. She looked fresh and not sleepy. Yes. But still.
She asked her mother to put bindi.
Yes. Very good. She asked her mother to put bindi. So Dr. Vijayakar has told this very nicely, that what is the first point of sign that your remedy is acting, that when lost interest comes back, when somebody tries to take back interest in his surrounding, that is the first sign of improvement. The improvement has to start at the soul level first, then the mind, and then the body. So fever will come down, cough will come down, it will take some time. But the improvement has to be at the level of soul. So her lost interest came back. She was interested in bindi. मेरे को दो बिंदी, मेरे को लगाओ, मेरी मम्मा को बोला मेरे को लगाओ बिंदी. So that is the lost interest is coming back. So in acutes, when we see in adults also, what the first question we ask over phone is, ये क्या कर रहा है? If the patient starts taking interest in the surrounding, if the child starts playing, if the child starts taking interest in the surrounding, we see, yes, my remedy is right and no need to panic. The child will get 100% better. So the lost interest has to come back. And I saw this child had a bindi on her head, and that made me be confident that yes, my remedy is right and she will improve. Remedy relationship, somebody says, has to be followed. So summary, what we have through this lecture, what I wanted to highlight is, prescribed for the man is disease and not disease in man. The child was having BCG lymphadenitis. You can know, if you prescribe tuberculin or thuja, that will not going to work. The right constitutional medicine is going to help. Prescribe for the child, not for the mother. In cases of acutes, if the picture is changed, prescribe the acute remedy. This is very important learning for you. Here I saw a picture change and the picture of opium erupting coming out very nicely. So I changed the remedy. Otherwise, most of the times, if the remedy is, if there is no change in picture, we prescribe the constitutional remedy only in acutes also. But if there is a change in thermals, change in thirst, or change in activity, you take the acute totality and prescribe. Sometimes the acute state is same as the constitutional state. Then you can prescribe the constitutional remedy. When treating deeper pathologies, exciseration has to be there. It will take few years. It took, this case took 3 years to excisorize, but the child was completely healthy. And to prescribe the reaction of patient is very important. So I think this was my sharing experience with pediatric cases and also acute. It was a very small, in nutshell, I have shared what I do in my clinic. Now, if you have any questions or doubt, you can ask me. I'll, whatever experience I have, whatever small knowledge I have, I'll try to, as possible as I'll try to solve your doubts. So Dr. Prachi, you can open up the forum and these people can ask me questions.
First of all, thank you very much, sir, for such a wonderful session, and yeah, and demonstrating the cases to us and sharing your experience. I think this will definitely help all the students and also to us also. And your important points mentioned in your session that first of all, you need to select the approach, that is whether the child is approaching or whether it is withdrawing child, or the, and then think of the group of the remedies. Then the basic importance to the reaction of the child, that is anger, fear, grief, and jealousy. This is again important thing, and important is not the first prescription but as well as the follow-up of the patient. These are the important points you are highlighted, and definitely we all take this and we'll try to apply in our practice. Now I think most of the queries has been addressed by sir, but still if anyone has a doubt, please ask the questions. You can type it in the chat box or you can unmute.
So Dr. Purti are asking about the dosage in infants, especially constitutional remedies. How frequently do we repeat? No change in the doses for an infant or a toddler or an adult. The theory remains the same. The approach remains the same. Single dose, infrequent repetition. Repetition only as and when required, which usually is 3 months or 4 months, once in 3 or 4 months. How do you select potencies for pediatric age group? Dr. Dhyana has asked this question. Pediatric age group, I have seen that higher potencies work better because the susceptibility is very high. They are not have, they most of them have not taken any long dosages of allopathic medicines, so they react very nicely. So higher potencies, they act better, but usually we start the case with 200. You can also start the case with 1 m, and more so in acutes, I prescribe 10 m single dose. So in acute, I prescribe 10 m, either 1 m or 10 m, most probably 10 m single dose, and that too in water. If the patient is in the clinic, then we take half a glass of water, just put 1 drop, stir it properly and give the water to drink. So 10 m single dose in acutes. In chronic constitutional, we start with 200, but also you can start with 1 m in cases of infants and children. What potency you prescribe? Yes, that's Dr. Raksha, same. Acute 10 m single dose, and in chronic, to start every case, most of the cases we start with 200. Infrequent repetition.
Sir, I have a question.
Yes, Shivani.
Sir, as we discussed that we should give medicine to child, but if mother has problem, mental issues, some, then we prescribe child. But just to avoid the tendency, we have to give medicine to mother as well, or we should skip it.
I'll tell you only few examples are there. We take mother's history also. Now, those examples are cases where we see a genetic problem or we see that the problem arising at the time of birth. So I'll give you a few examples. Suppose there's a case of Down syndrome. We know the problem has started not after the birth, but long before the birth. So there we also take mother's history during pregnancy. That at that time, mother's history is very important. But still, again, whatever inferences, the mother's history is not important, but the indications or ailments from or the state of mother is important. And that state we have to corroborate with the presenting complaints of the child. So if you see a mother had an episode of anger and she was very angry and she suppressed her anger. And now if you see a child of Down syndrome or autism, where you trace that the problem started right from the womb, then we might take ailments from suppressed anger as a symptom. But we never ignore the child, take history of the mother and prescribe the mother's remedy to the child. No, that we never do. Similia similibus curantur. So whenever you want to prescribe for the child, the totality of the child has to match. It is not of the mother. But yes, cases, genetic cases, their mother's history is very important because we know the start point from where it has started. Right, Shivani?
Yes, sir.
Okay. So genetic cases, or I had now a case of cyst in the kidney, where we took mother's history, we tried to understand the mother's trace, then corroborated that history with the child and then prescribed. But it has always the primary focus, the primary remedy is for the child, not for the mother. How to know the grief reaction in the children? Very easy. Grief means they will not express, they will feel bad. So you, in child also and in adult also, you ask whether you feel bad or feel angry. If the child feels bad, we take it as grief. If the child feels angry, we take it as anger. I have few videos where I could have shown you those grief reactions, but next time I'll show you those reactions also, grief reactions. How to take thermals in infant? Very easily. You try to ask about the child's reaction and also the reaction of mother. So there are few hints which we take. First thing is see whether the child likes to be covered or not. So we ask parents directly that compared to others in the house, compared to you, is the child more comfortable in a colder environment or in a warmer environment? Then we try to see the temperature of the child. If the child is covered, by try to see the temperature of the child inside, like in the chest and inside of the thighs. And there are few others. I have explained those how to take thermals in my book Essential of Pediatrics. So you can understand thermals very easily in infant. And in case of doubt, if you're not clear of thermals, that time you can ignore also. Don't try to fit in, but if you're very sure of thermals, take the thermals. Gelsemium and Lyco. So Gelsemium basically is a chili remedy, and Gelsemium, the fright will be more, dullness will be more compared to Lyco. Yes, any other questions?
Yes, anyone else? So actually, my question is not related to this topic, but just a general question that what is your opinion regarding vaccination? Can we give constitutional medicine in spite of vaccines, the convention, whatever used in the conventional method?
No. Basically, you don't require even to give constitutional remedy. But if you see some symptoms in a child, if you say that a child's immunity is down, that you can very easily understand, then you give the constitutional remedy. Vaccination is very tricky subject, and that's what I know, that the question of vaccination made me go towards pediatric, because when my child was there and the same question and same doubt arise what to do, and that led me to go into details of child's pediatric understanding, how to find remedies in the child. So vaccination normally I don't advise, but very tricky question, because government recommendations are there. The law says that you should vaccinate. So you leave the choice on the patient. you give your example. You say that I have not vaccinated my child. If you want, you can go ahead and vaccinate. If you don't want, then we'll give you medicines. You can skip the vaccinations also.
Okay, thank you, sir. Thank you for such a wonderful session, sir, again. And now I hand over to Dr. Sonali. She is the assistant professor in the department for a vote of thanks. Thank you.
Thank you, Prakshi ma'am. Any duty cannot be said to be completed without offering our thanks and gratitude to all the members who are involved in conducting such activities. I, Dr. Sonali Tambewag, Assistant Professor in the Department of Pediatrics, feels very privileged to express my gratitude to all the members who are being involved in making today's webinar a great success. First and foremost, I would like to extend my gratitude to our chairman, Dr. G.D. Paul sir, who is a source of constant support and inspiration for all of us for conducting such enlightening activities. Also, I would like to express my gratitude to our principal, Dr. Page ma'am, for her motivation and encouragement for conducting this series of national webinars. I would also like to express my sincere thanks to our vice principal and dean faculty homeopathy at MUHS, Dr. D.G. Bagal sir, for his constant guidance and cooperation for successful activity of the series of national webinar. I extend my thanks to our esteemed speaker of today's webinar, Dr. Praveen Jain sir, for explaining very briefly, very efficiently about the homeopathic management in pediatric disorder and understanding what are the difficulties faced by the pediatric homeopathic physician and how to overcome those difficulties, and elaborating about the basics of pediatrics, about the withdrawal and approaching child, and also clearing many of our doubts and enhancing our knowledge. My sincere thanks to all the viewers and audiences who were there for today's webinar. Sincere thanks to all the teaching and non-teaching faculty members for their contribution and support. My heartfelt thanks to organizing committee and the technical team. Without their support, today's webinar cannot be possible. With this, my vote of thanks, I conclude the today's session. So thank you, sir. Thank you, all of you. Have a great day ahead.
Thank you all.
Thank you, sir. Thank you so much.